Hi everyone, my name is Mackenzie Wilkinson, and my case study for drugs affecting the respiratory system was on inhaler refills. So my case study involved a patient coming in with the complaint of I need a refill for my inhaler. Just to give you some history, Rick, age 25, is being seen in the clinic for the first time. He recently moved to the area and is establishing with me as a primary provider. His chief complaint is that he needs a refill for his asthma inhalers and is hoping that I will know more about asthma than the last provider because his asthma has never been under control in spite of trying many different inhalers. He has never seen an asthma specialist and has never had a written asthma treatment plan. Rick reports having asthma all his life, beginning in early childhood, and as a child, he remembers being hospitalized a couple times for asthma. He reports the mainstay of his treatment has been to use an albuterol inhaler the past few years. He remembers using oral medicine before, but cannot remember the name. He has no other health problems except that he smokes 1 pack of cigarettes per day. And upon further exploration, he reports that he used the different inhalers for only a short time because they did not work. Rick's examination is normal except for soft expiratory wheezes and a loose cough. He did have his albuterol inhaler with him, and when asked to demonstrate the use of his inhaler, he demonstrated poor technique. So to begin with tackling Rick's situation, we need to understand what asthma is, and it can be considered a chronic inflammatory disorder of the airways. There's variable or waxing and waning of airflow obstruction in asthma, and there's also airway hyperresponsiveness, which is an exaggerated contracting response of the airways to a variety of different stimuli. And the pathogenesis of asthma involves complex interactions between inflammatory and resident airway cells. Mast cells, eosinophils, lymphocytes, dendritic cells, and their associated products are all very prominent in the airways of patients with asthma. And inflammatory events and associated alterations in the airway smooth muscle function and structural changes are what makes the asthma symptoms occur. Bronchial hyperresponsiveness is a defining feature of asthma, and it's manifested by an exaggerated reversible airway obstruction due to smooth muscle contraction. Structural cells, particularly the epithelium, fibroblasts, smooth muscle, and endothelium all may contribute to inflammation or airway remodeling. And there's a variety of genetic, environmental, and infectious factors that all appear to modulate whether susceptible people progress to overt asthma. The classic signs and symptoms of asthma are intermittent shortness of breath or difficulty breathing, cough and wheezing, and chest tightness. All of these symptoms are nonspecific, and this makes it difficult to distinguish asthma from other respiratory diseases. The symptoms are variable and they're recurring, and they're usually brought on by characteristic triggers and also relieved by bronchodilating medications or by the avoidance of those triggers. And in the photo to the right, you can see the comparison between a normal bronchiole and an asthmatic bronchiole. The asthmatic bronchiole is obviously a lot more constricting, which will give you the shortness of breath, difficulty breathing, wheezing, chest tightness, and then there's mucus in there as well, so you can have that mucousy cough as well. Cough, wheeze, shortness of breath, and chest tightness are all characteristic of asthma. However, those symptoms are also found in a number of other respiratory diseases that affect both the upper and lower respiratory tracts. So this can make it a little bit difficult to distinguish the two. So I've provided some differential diagnoses to asthma. When persistent cough is the presenting complaint and the patient's lung function and chest x-ray are normal, there could be a differential diagnosis of rhinitis or rhinosinusitis, gastroesophageal reflux disease or GERD, post-viral tussive syndrome, cough induced by ACE inhibitor medication, or infection with Bordetella pertussis or whooping cough. Also, a chronic cough with mucus sputum production in a long-term cigarette smoker would point to a diagnosis of chronic bronchitis. Generally, that's more than 10 pack years. So in Rick's case, he's 25 and smokes a pack a day. There would need to be more questioning on how long he's been smoking for to kind of lean more towards the chronic bronchitis diagnosis, but there's other factors that we'll look into, but that is a possibility. Shortness of breath is a very broad, common symptom of a lot of different diseases. So some of the most common causes in the adult that might be confused with asthma would be COPD, heart failure, pulmonary embolism, and sarcoidosis. And then different types of wheezes can determine other diagnoses like vocal cord dysfunction and bronchogenic carcinoma or foreign body aspiration. These are some different types of wheezes that should not be confused with asthma and to keep an eye out for. To assessing, evaluating, and diagnosing asthma, some of the clinical features to look for is that asthma can develop at any age, but the majority of them are diagnosed in childhood, like in Rick's case. And obtaining clinical history in adults should question the presence of symptoms earlier in life. And then some other clues that suggest asthma would be recurring episodic symptoms, presence of typical triggers like exercise, exertion in cold air, or allergen exposure, and also a personal or family history of allergic disease. A physical examination might be normal in someone with asthma. However, the presence of abnormal findings like wheezing is suggestive of asthma, although it's not specific, as we just talked about before. And then you can also do a nasal examination with an office otoscope, and this could be done to check for pale or swollen mucosa. That would be associated with allergic rhinitis or full nasal polyps, which could raise the possibility of aspirin-exacerbated respiratory disease. I'm not going to go too deep into the evaluations for asthma. However, pulmonary function tests are the most helpful in diagnosing asthma, and these would include spirometry, pre- and post-bronchodilator, bronchoprovocation testing, which is usually done with methacholine, and also peak expiratory flow or PEF monitoring. Lab tests are sometimes indicated to identify potential asthma triggers or to exclude alternative diagnoses, and these can include blood tests like a CBC. You can do a total serum, IgE, etc. There's also skin testing for environmental allergies and also chest x-rays. A chest x-ray is not routinely recommended as part of the diagnostic evaluation for asthma. However, sometimes they are obtained in patients who have atypical features like chronic purulent sputum production, persistent local wheezing, inspiratory crackles, fever, or clubbing, and also for new onset, moderate to severe asthma in adults over the age of 40. Overall, the diagnosis of asthma is based on the presence or history of symptoms that are consistent with asthma, like the cough, wheezing, and shortness of breath that's provoked by typical triggers, in combination with pulmonary function tests that show variable expiratory airflow obstruction. The main goals of asthma management are to optimize control of asthma symptoms and reduce the risk of asthma exacerbations, prevent decreased lung function, and also minimize medication adverse effects. It's expected that a person who has well-controlled asthma should be able to participate in work, school, play, and sports without limitation due to their breathing, so this is ultimately the goal. Optimizing control of symptoms and having just overall good control of asthma would mean to reduce the intensity and frequency of asthma symptoms and also maintain normal or near normal activity levels. Specific goals for asthma control would include freedom from frequent or troublesome symptoms of asthma like cough, chest tightness, wheezing, or shortness of breath. Few nighttime awakenings, specifically less than 2 nights per month due to asthma. Minimal need, optimally less than 2 days per week for medication for acute relief of asthma symptoms. Optimize lung function, maintenance of normal daily activities, including work or school attendance and participation in athletics and exercise, and also satisfaction with asthma care on the part of patients and caregivers. So my goal for Rick would be to control his symptoms of cough and wheezing and any other symptoms that he would be having after more evaluation. And then also to make sure that he is satisfied with his care and feels like his asthma is under control, because he had dissatisfaction with his previous provider and didn't feel like his asthma was ever under control. Specific goals for reducing future risk would include prevention of recurrent exacerbations and need for emergency department or hospital care, prevention of loss of lung function in adults that would be due to poor asthma control, and also optimization of medication therapy with minimal or no adverse effects. Risk factors for future exacerbations would include a history of 1 or more exacerbations in the past year, poor adherence to asthma medication, incorrect inhaler technique, low lung function, smoking or vaping, an elevated concentration of exhaled nitric oxide or fractional exhaled nitric oxide, and blood eosinophilia. Based on the case study information, Rick has some risk factors for future exacerbations, so that's just something to keep in mind. He is a smoker. He smokes a pack a day. Also, when told to demonstrate his albuterol inhaler, he had incorrect inhaler technique. And I would also probably suspect poor adherence to medication, because he stated that he had taken some different inhalers for a short period of time but just stopped because they weren't working. One of the initial assessments that you would do is to determine asthma severity. This typically would occur around the time of diagnosis. Since Rick already kind of has the diagnosis of asthma, but this is my first time seeing him, I would definitely do an assessment regarding his asthma severity, because this will help guide the intensity of therapy that would be needed to bring his asthma under good control. And asthma severity is determined by multiple factors, including airway hyperresponsiveness and predisposition to allergy, environmental factors such as irritants, viral agents, and allergen exposures, and also comorbidities such as obesity or chronic rhinosinusitis. Also, determining asthma severity is good to help categorize patients who are not yet taking medication for control of their asthma, or who are taking only a short-acting bronchodilator for symptom relief, which would be Rick's case. He only takes the albuterol inhaler right now. Now, the assessment of asthma control is applicable to all patients regardless of their medication use, and it should be assessed at every patient encounter. You should note the frequency of their symptoms and also risk factors for exacerbations. In addition to that, assessment should also include their lung function and people that are old enough to perform that testing. Both asthma severity and asthma control are determined by considering the following factors listed here: reported frequency and severity of daytime symptoms, in addition to nocturnal awakenings over the previous 4 weeks, number of exacerbations requiring oral glucocorticoids in the previous year, and also current level of lung function if the person is able to perform this testing. In the case study, Rick had mentioned that he did take some type of oral medication for his asthma a few times, and that he also was hospitalized as a child multiple times for his asthma. This is something that I would look further into to determine the frequency of exacerbations and about how many times he had required some type of oral steroid in the past, because this would help determine his asthma control and severity and help guide treatment. The National Asthma Education and Prevention Program, or NAEPP, and the Global Initiative for Asthma, or GINA, have this wonderful chart that bases initial therapy on assessment of asthma symptoms, including the frequency and intensity, respiratory impairment, and also the risk of poor asthma outcomes. And it comes with this lovely little chart where you can basically look at their symptoms and lung function, and it gives you a recommendation on the therapy to start, and then how to progress from there. So there's a couple different categories of asthma severity that I'm going to run through really quickly here, just so that you can see where and why I placed Rick where I did, based on the information that I was given in my case study. So intermittent asthma would be characterized by the following: daytime asthma symptoms occurring 2 or less days per week, 2 or less nocturnal wakings per month, use of short-acting beta-agonists to relieve symptoms 2 or less days per week, no interference with normal activities between exacerbations. There's some measurements from spirometry. I didn't get too far into those, but I did list those there. And then 1 or no exacerbations requiring oral steroids per year. And then if any of these features is more severe than what's listed, then the asthma would be categorized as persistent. So mild persistent asthma would be characterized by the following: symptoms more than twice weekly, but less than daily, approximately 3 to 4 nocturnal awakenings per month, but fewer than every week, use of short-acting beta-agonists to relieve symptoms more than 2 days out of the week, but not daily, minor interference with normal activities, and then there's some spirometry measurements there. Now, any of the following features would be considered an indication of moderate persistent asthma: daily symptoms of asthma, nocturnal awakenings as often as once per week, daily need for reliever therapy for symptom relief, severe limitation in normal activity, and then also some spirometry measurements there as well. Now, this is the asthma severity category that I put Rick into. It did state that he had wheezing and coughing during his assessment. I'm assuming that these are probably daily symptoms for him. And I'm also just assuming that he probably uses his albuterol inhaler daily, just because he did say that he had tried multiple inhalers in the past and that they didn't work. So I'm just assuming that his asthma is probably a little bit more severe than just mild, persistent, or just intermittent asthma. I didn't qualify it as severe persistent, which I'll discuss in the next slide, but I felt like this was a good fit for the information that I was given in his case study. But obviously more assessment and evaluation would need to be done to determine exactly how severe his asthma is. So severe persistent asthma would be manifested by asthma symptoms that occur throughout the day, nocturnal awakening due to asthma every night, reliever medication needed for symptoms several times a day, and extreme activity limitation due to asthma. The World Health Organization has definitions of severe asthma that include this useful subcategory for patients. Patients are considered to have difficult to treat severe asthma if they have poor asthma control despite treatment due to confounding or potentially remediable factors like poor medication adherence, allergen or irritant exposures in their home or work environment, or treatable comorbidities. And then the other subcategory that patients could fall into would be treatment-resistant severe asthma, and these patients would have poor asthma control despite good medication adherence, modification of environmental exposures, and management of comorbidities. These patients that fall under this category are likely candidates for biological agents and would require consultation to a pulmonologist. Pharmacological treatment is considered the mainstay of management in most patients that have asthma, and there's national and international guidelines that advise initiating therapy based on the frequency and severity of symptoms and also the results of lung function measurement. The choice of medication is based on a couple different factors, age being one of them, the patient's symptoms, lung function, risk factors for exacerbations, patient preference, and also practical issues such as their ability to use medication delivery devices and also their accessibility to medication. So for all patients with symptoms of an asthma exacerbation, it's recommended that they're treated with prompt administration of a short-acting beta agonist, such as albuterol. These patients also will probably require a brief course of systemic steroids. In addition to, they will either need a long-term controller medication initiated, or most likely their medication will need to be adjusted after the asthma exacerbation is done. Initiating therapy in previously untreated patients. All patients with asthma should have immediate access to an inhaled bronchodilator with a rapid onset of action in order to have prompt relief of their asthma symptoms. The traditional and preferred choice is a short-acting beta agonist like albuterol or levobuterol. An alternative to this is to use a combination low-dose glucocorticoid and formoterol inhaler. Formoterol is a fast-acting, long-acting beta agonist, or a LABA, and this can be used PRN as an alternative therapy to albuterol. And then depending on the severity of the patient's asthma, they may need initiation of a controller medication as well. So again, patients that have intermittent asthma need to have immediate access to an inhaled bronchodilator that has a rapid onset. The traditional and preferred medication is albuterol, and that's a short-acting beta agonist. The Global Initiative for Asthma, or GINA, also recommends that these patients that are dependent on a short-acting beta agonist for symptom relief also have a low-dose glucocorticoid inhaler that they can use as needed. The downfall to that is that the patients would be required to carry 2 separate inhalers for intermittent as-needed use. So an alternative to that would be a combination low-dose glucocorticoid formoterol inhaler, or Symbicort, the medication I talked about on the previous slide. This can also be used PRN like albuterol. The advantage to this is that with the glucocorticoid in it, it will treat the chronic airway inflammation that's thought to be present even in intermittent asthma, and this will reduce the risk of severe and potentially life-threatening asthma attacks that can occur in these patients. Also, when the triggering of asthma symptoms can be predicted, like with exercise, pre-treatment with the short-acting beta agonist or the Symbicort can be used approximately 5 to 20 minutes prior to whatever the exposure is, and this will help to blunt or prevent the onset of symptoms. For patients with mild persistent asthma, it's recommended that the regimen includes a low-dose inhaled steroid. This is because regular use of inhaled steroids will reduce the frequency of symptoms and therefore the need for short-acting beta agonists for symptom relief. So the recommendation is a low-dose inhaled glucocorticoid daily, or the combination of a low-dose steroid and long-acting beta agonist, such as Symbicort, which I discussed earlier. And then an alternative to both of these, if inhaled steroids is not an option for the patient, would be a leukotriene modifier like Montelukast. However, these meds are generally less effective. In patients with moderate persistent asthma, the preferred controller therapy is the combination low-dose inhaled steroid and long-acting beta agonist and a single inhaler. This is Symbicort. And because of that rapid onset action of formoterol that's in that combination, it can be used both for daily controller therapy as well as quick relief of symptoms. This strategy is referred to as SMART, or single inhaler maintenance and reliever therapy. The advantages of the SMART strategy are that a patient is only required to master the use of and keep with them 1 inhaler rather than 2, which would be very good for Rick's situation. And the other advantage is that the patient receives additional inhaled steroid when the symptoms flare and acute relief of the symptoms is needed. An alternative to that is patients can use a low-dose inhaled steroid and long-acting beta agonist combo daily with a short-acting beta agonist for acute relief of symptoms. However, this would have patients carry 2 different inhalers. And this is an alternative because at one point, long-acting beta agonists were thought to have an increased risk of severe and life-threatening asthma attacks. However, there were multiple large randomized controlled trials that were done that did not find this association, so the original black box warning that was in all long-acting beta agonist has been removed. So that is why the alternative with the Symbicort is
preferred as maintenance therapy and as a reliever therapy. An alternative to that, an inhaled long-acting muscarinic antagonist can be used with an inhaled steroid. It's been proven to be equally effective compared to Symbicort. And this option would be appropriate for any patient that can't tolerate long-acting beta agonists or even limited sympathetic stimulation is contraindicated. However, it does require 2 separate inhaler devices with 2 different inhaler techniques as well. And another alternative to those is a leukotriene modifier like Montelukast and a low-dose inhaled steroid. However, this is overall less effective. For severe persistent asthma, controller therapy is medium and high-dose inhaled steroids in combination with the long-acting beta agonist. However, it is important to note that these patients that are receiving medium to high-dose inhaled steroids need more careful monitoring because of adverse effects. Also, depending on their treatment response, these patients may need additional therapy with a leukotriene modifier, a long-acting muscarinic antagonist, or a biologic agent. And then also there is a triple combination inhaler called Trelegy that includes a inhaled steroid, a long-acting beta agonist, and a long-acting muscarinic antagonist as well. In order to manage asthma properly, there needs to be a proactive and preventative approach, kind of like you would do with hypertension or diabetes. So routine follow-up visits are recommended for patients that have active asthma, usually every 1 to 6 months, depending on the severity and adequacy of their control. And at these follow-up visits, you should be assessing their asthma control, lung function, exacerbations, their inhaler technique, adherence to their medications, any adverse side effects that they're having from them, their quality of life, and also their patient satisfaction with their care. At the follow-up, the patient's symptoms over the past 4 weeks should be assessed at every visit, and it should assess their daytime symptoms, nighttime awakenings, frequency that they need to use a short-acting beta agonist to relieve their symptoms, and if they're having any difficulty in performing normal activities or exercise. And there are actually several quick and validated questionnaires. I provided one here on the right. This is the asthma control test. You can use it on children and adults, but it just provides a standardized method for scoring their asthma control and to be able to record any changes that they're having over time. Also, just a side note, we did already talk about their assessment risk for future exacerbations. However, this is important to periodically go back and revisit with patients just because it can change. And some of the risk factors that could change would be if a person started smoking or vaping, or if they started to be exposed to more allergens that are triggering their responses. So if you're having issues with exacerbations, this could be an area just to revisit with them during follow-up as well. So more follow-up monitoring is monitoring the patient's pulmonary function. Spirometry is the preferred method. Peak expiratory flow, or PEF, with a peak flow meter is an alternative. However, guidelines prefer to use the spirometry over that in the office because there's greater accuracy of the measurement when performed by skilled technical staff. And the spirometry measures the forced expiratory volume and also the forced vital capacity. It's sensitive and can be reproducible for assessing airflow limitation, and it uses a ratio to determine that. And it can also detect reductions in lung function that indicate a loss of the patient's asthma control and also a risk for a severe asthma exacerbation. Typically, it's obtained approximately every 1 to 2 years when the patient's asthma is stable, but it is done more frequently if it's not well controlled or their medications are being adjusted. Alternatively, peak expiratory flow, or PEF, can be measured with a PEF flow meter. This can be done with little training. The cost is very low. And this is best for patients where the diagnosis of asthma has already been previously established with spirometry, because these PEF values can be correlated with the peak flow measurement that was made by spirometry. It is important to understand, though, there are limitations to it, and the accuracy is also limited, so that is why spirometry is preferred over it. Patients can also do these measurements at home with a peak flow meter. These are useful for determining relative changes or trends in their asthma control, specifically in patients with moderate to severe asthma. And it is very helpful in patients that have a poor perception of airflow limitation, because these patients lack a awareness of increasing impairment with their asthma, and then they typically seek care for exacerbations only once their symptoms become severe. So once they determine a good baseline value of their peak flow and FEV, then they can see if their range is less than 80% of their personal best rating. It may indicate airway narrowing, which is a change that can occur before they even perceive their own symptoms. And peak flow meters are widely available. They're inexpensive. They're approximately $20, and they're very easy to use. However, the measurements are highly dependent on the patient's technique, so it is important to assess this in the office and correct any mistakes in their technique if needed. I did include a chart to the right that shows predicted PEF measurements for males aged 20 to 70 based on their height. So patients could use that for reference, and then you can also give them a chart for recording their PEF values for at home as well. Now, there are methods to assess airway inflammation, like blood and sputum eosinophil counts, and also fractional exhaled nitric oxide. However, these aren't used very widely for disease monitoring. They're more so used in selected patients to determine their likelihood of response to a change in inhaled steroid dose, or if they're a candidate for one of the biologic therapies. There's also a number of comorbid conditions that contribute to asthma symptoms depending on the specific condition, so it is important to look at those and try to control those as best as possible. For patients already taking one or more controller medications, therapy can be adjusted in a stepwise fashion according to the National Asthma Education and Prevention Program and the Global Initiative for Asthma Guidelines. These are in a tier or step approach, where you either step up or step down their treatment depending on their asthma control and severity, and also medication side effects. These guidelines were the chart that I showed earlier that just helps guide treatment and recommends certain medications depending on the patient's assessment and evaluation. In patients with poorly controlled asthma, their therapy will be stepped up according to the guideline tiers, and it may be necessary to escalate their therapy more than one step. However, it can then be stepped down once good control is achieved. Stepping down therapy is considered when asthma has been well controlled for 3 to 6 months on a stable regimen. This helps to minimize the patient's expense, just inconvenience overall, and any potential immediate adverse effects. And then it is also good to reduce the patient's long-term exposure to high doses of inhaled steroids. Alternatively, when following up with patients' medications, patients that have their asthma well controlled, their medications could continue unchanged, especially if they have a history of serious exacerbations in the past or they're at high risk for future exacerbation. Referral for consultation or co-management depends on the experience of the primary care provider with asthma care, but pulmonologists and allergists or immunologists have special training in asthma care, and referral to them is generally advisable under any of the following circumstances. One of the key components of optimizing a patient's asthma control is having a patient that is well informed and motivated, and also have them well engaged in their asthma management. Overall, this will decrease their exacerbations and hospitalizations and improve their daily function and satisfaction with their care overall. The NAEPP has guidelines for patient education regarding asthma care, and those are listed over to the right. However, the 3 most important topics of patient education would include the function and appropriate use of their medication, them understanding the pathophysiology of asthma, and also the prevention and treatment of symptoms that they have. And it is also important for them to understand what airway inflammation is, sensitivity to triggers, and also temporary occurrence of airflow obstruction that leads to shortness of breath, and how to handle those situations. Up to date is where I've found a lot of the recommendations and guidelines for asthma management in this PowerPoint, and they also offer some really good education materials. The 2 different ones that they have are the basics and beyond the basics. The basics is obviously a little more simplified, more for a 5th to 6th grade reading level. And then beyond the basics is some longer, more sophisticated, more detailed pieces, and that's for like a 10th to 12th grade reading level. I've included in one of the handouts for asthma management over on the right side there that you can see. Direct one-on-one education with your patient is the most effective and well supported by evidence. However, there are numerous additional resources that are available for asthma education on some online sources like the Asthma and Allergy Foundation of America, organized community programs, and also from asthma educators as well. And just some other areas to highlight with patient education that are very important are their technique for using each type of inhaler, which is very important in Rick's case because obviously he showed that he did not know the correct technique for using his albuterol inhaler, which is probably why it wasn't working for him. And to also identify any environmental triggers and coexisting conditions, recognizing symptoms of exacerbation and what to do in those situations. And then there are also questionnaires that are available that help determine what a patient's strengths and weaknesses are in their self-management, and education regarding their asthma care that you can give. And I listed one of those over on the right side there. So you can give that to your patient if you're trying to incorporate some patient education into your visit. And then each patient should also have a personalized action plan, which I will talk about on the next slide.
Every patient should receive a personalized asthma action plan. This is a written document that provides the patient instructions to follow at home. It helps to clarify the patient's medication regimen, and it also helps them to identify any declines in their asthma control. And it also aids in guiding treatment adjustments in response to changes in symptoms and any home measurement PEF values that they're recording there. There's several different asthma action plan forms available through various organizations like the NAEPP, which I've been referring to a lot in this PowerPoint, and also the American Academy of Allergy, Asthma, and Immunology has a really good one, and I have included one of those on the right side there. So you just fill it out and personalize it for your patient, and then they get to take it home and refer to it as needed. This is something that would be very beneficial for Rick in his case because he has never received one of these, and from the case study, it seems like he has a lack of education and not very good control over his asthma and overall just understanding of his treatment regimen and what to do. So this is a very important aspect of his care that I would include. I know I talked a little bit about Rick's specific treatment throughout the PowerPoint. However, I just want to kind of summarize his specific treatment now that we're at the end of the PowerPoint. And like I said, based on his case study, I categorized his asthma as moderate persistent. And according to those NAEPP and GINA guidelines for treatment, I would most likely start him on a Symbicort inhaler, using that SMART strategy where we use it as a maintenance and controller therapy, but also as a reliever regimen. I think that the Symbicort would be a good choice for him because it combines the steroid and the long-acting beta agonist into one inhaler, so that he wouldn't need to carry two separate inhalers with an albuterol and then an additional steroid inhaler. This will just make it a lot more convenient for him and easier to understand. So for dosing, I would go with the budesonide 80 mics and the formoterol 4.5 mics. Oral inhalation, we would do 2 inhalations 2 times a day for a max dose of 12 inhalations a day, and this would include for reliever therapy. And so for the reliever therapy component of it, he could do 1 to 2 inhalations every 20 minutes for up to 3 doses or for an hour, or 6 inhalations per exacerbation. Education would be a huge component of Rick's treatment, especially making sure that he can properly use his inhaler. I've included education from Up to Date over on the right side there that I would give to him, but I would also have him demonstrate in the office so I could correct any of his technique, but I would definitely touch on how to prime and shake the inhaler for 5 seconds before each inhalation, and also to inhale until the lungs are full and have that breath hold for 5 to 10 seconds after inhaling, and explain to him that when you don't do that, you can get that medication deposited in the back of your throat, and it can lead to inefficient medication delivery and also cause hoarseness and thrush. And also because he's using the glucocorticoid in that inhaler, it's important that he rinses his mouth out with water, gargles, and spits. And then, as talked about before, I would definitely make sure that we have an asthma action plan personalized for Rick, just to give him some education on daily asthma care, and then also attack management, when to detect symptoms and initiate rescue treatment, or indications that he needs to go to emergency department. Another important component of Rick's specific treatment would be education on smoking cessation.
he does smoke a pack a day, it would be important to educate him that this activity increases his risk for future exacerbation and impacts his asthma overall. So providing him with supportive resources and medication if necessary to help him quit would be very important. I would also have Rick follow up with me in 1 month. At that follow-up appointment, I would administer the asthma control test questionnaire just to kind of gauge where he's at with his asthma control. That would be a way of assessing control. I would assess his lung function, exacerbations if he had any. I would have him demonstrate the use of his inhaler and critique any of his techniques. Make sure that he's adhering to the medical or medication drug regimen. Ask if he's having any adverse effects, and then just overall how his quality of life has been and if he is satisfied with the treatment regimen so far. And depending on his assessment and evaluation, an option that would be available if his symptoms were not controlled would be to step up that medication based on those guidelines, where we could increase his dose to 160 mics and 4.5 mics 2 times a day with the max 12 inhalations a day. And then also at that follow-up appointment, I would administer some type of patient education questionnaire to see where his strengths and weaknesses are so I could provide more education for him. So some critical thinking questions that I have for you are, number 1, why would COPD be an unlikely differential diagnosis to asthma in Rick's case? Number 2, what are the most common asthma triggers and ways to avoid them? And 3, what are some major side effects and causes for concern regarding inhaled steroids? And here are my references from UpToDate. I hope you guys enjoyed this PowerPoint and presentation, and thank you for listening.